My question is to the radiation oncologist here. Sir, what will be the surgically safe RT dose for esophagus so that in trials like SANO, could we have escalated the dose? Because definitive more than 50 we are giving CROSS 41.4. Anything in between would have given better clinical complete response rates.
So the question is the radiation dose pre-surgery. What is the safe dose pre-surgery? So as of today, it is still 41.4 gray, the neoadjuvant dose used in CROSS. The complication rates have been always been higher with the full dose 50.4 gray, followed by surgery, followed by salvage esophagectomy. So as of today, if you are attempting surgery down the line, we should stick to the CROSS trial protocol only.
But SANO trial was it, if it was for intention to cure an trial, then dose could have been adjusted or would have been helped in the results. Just so your opinion on that.
Even in the SANO trial with the 41.4 gray CROSS dose, 35% patients achieved a complete clinical response. And escalating dose beyond 50.4 has never been fruitful. In the older radiation trials, I think the intergroup 0123 trial and then the recent ART-DECO trial, both the trials they failed. They escalated from 50 to 60 or 64 gray and both the trials were negative. And now, although it is a common practice, what I see, but the evidence-wise, escalating dose has never shown improvement in survival or local regional control. So as of today, you have to stick to the current evidence, give 41.4 gray. If there is a clinical complete response, you have the option of following the SANO trial protocol, or else you then proceed for surgery.
How many gastroenterologists are there on the floor? Only one, sorry. Just an open question. If it is yourself or myself, and there is one particular question they have asked, patient choice. It's very difficult to judge. So in Western world, what we call as NEDS, National Endoscopy Database. So every endoscopy you do, you have to have certain dysplasia detection rates or polyp detection rate. And we don't have that, number one. Number two, any skill, if you don't use it, it gets de-skilled. And the volume of work is more important and your risk is associated with it. And just one question, what would be the polyp detection rate, an average polyp detection rate that is normally generally considered universal?
So polyp detection rate, it depends on the organ you are
let's talk about the colon or
so
the
if you
dysplasia.
mean it's colon, then usually the Western data would be different from the Eastern data, that we should know that. You cannot go with the Western guidelines for the Indian guidelines. So Western guidelines, they say that the polyp detection should be nearly 40%, with adenoma detection has to be 30%. But in Indian scenarios, like with increasing colonoscopies, we are finding those, but we don't have any specific data. Only one of the data from the unpublished, and it's came from the news article from Continental. They are saying it's around 30%. But Indian definite data going into guidelines is not there. That's why even screening colonoscopy in Indian settings is a controversial topic.
So going back from the point I said, when I came here, there is never a diagnosis of IBD before, never a cancers that was defined. The reason is that it was the same scenario. What is the withdrawal rate on colonoscopy? How much time do you take to withdraw the colonoscope? The reason is the polyp detection rate depends on the time you take, because you need to spend time, you need to clean it, and your quality of surveillance is what is important. Leading to the question is how many minimum polyps you need to remove and the size. Because when we train the endoscopy nurses in UK, anything less than 2 centimeters, they can be given to any gastroenterologist. Anything over 2 centimeters of flat polyps, they have a high risk of bleeding and perforations. So hence it should be only done by high volume, specific, with relatively less complication. We mean complications less than 1%, because it's all audited, and every week, every month we have endoscopy user group meeting. We have to scrutiny the reasons why it behind. Because if you had one bleeding or one perforation, you'll be stopped from performing procedures until you have a further training. So the reason I'm saying is the screening depends on your withdrawal time and also the quality of whatever the organ you're doing. For example, upper GI, you need to make sure the saliva is taken away, and you need to spend time, and you need to know why you're screening first. so that your detection rates will go up. Number of patients here, they come, I'm diabetic, they eat food and they ask you to do the endoscopy. Because we are competing for one another, people are doing it. That's one thing. Number two, high volume, then only you touch the patient. If not, if you're not going to guarantee the good outcomes for the patient, I think rediscussing with the patients what is the risk of recurrence and also the endoscopic complications. You talk to the patient. If it is me, if I say whatever the complexity or the flat polyps of more than 2 centimeters and it's closer to different organs, if I was given a risk of perforation and the closure is difficult, I would rather choose a surgery. That's what I'm trying to get to. So it's not about anything else, because you need to have the high volume to maintain your competencies, and it has to be documented centrally to be evident for the patient to make the right choices. That's the point I was trying to make. Thank you.